there's a great booklet that Carl Wheel has, and I'll have some next week. Just a quick reference for back backcountry medical care by Wilderness Medicine Outfitters, and I've got a bunch of these. It's just got some real easy, nice pages to it. It's hard to carry these kind of books with all the proper ways and proper medical terms and legalese and all that when you're on an emergency scene. I'd much rather pick up something here that says, make sure you're not in danger, put medical gloves on for your cat, be positive with all, refer to the intubation of the patient, be supportive of him, do a better job, take a deep breath, and methodically go over what happened. Tell me. Tell me what happened. We're talking subjectively. Subjectively means how bad does it hurt on a scale of 1 to 10? When I talk about mechanism of injury or nature of illness, I'm saying, when did you start getting sick? You see where I'm coming from? Did you fall off the cliff, fall off the ladder, or get kicked by a horse? Get shot by a gun? What happened? I'm asking the person. Now, what I'm really doing is finding out how alert this person is. Because there's another MEMRIC, which is AVPU. Is he alert? Can I say, hi, when's the last time you ate? And he said, 2 hours. What'd you have? Ham and eggs, toast with butter. That person's alert. If he's vocal and he's not alert, he just might go, I had breakfast, eggs. Well, at least then he's vocal. If he doesn't say anything and you rub his shoulder or pinch him a little bit and they go, oh, then they're pain. And if they don't respond to any of this, they're unresponsive. Then we tell the paramedics or we tell whatever, we write it down, AVPU. The person was alert or he was vocal or he was pain or he was unresponsive. This is the same training where it goes to Carl's, American Association of Orthopedic Surgeons, Health and Safety, ESI, etc. This is basically across the board. AVPU, is he alert? You're trying to find out what his level of consciousness is. 2.5 years ago, I had a nasty, nasty fall at a Walmart of all things, and I didn't open my eyes for 6 hours. I was talking, so therefore I was not alert, but I was vocal. You see? So that's what, anyway, right on. When I find out objectively, I mean subjectively, what happened, what's going on, man? I cannot tell if somebody's dizzy. I cannot tell if they feel reeling. I can't tell if they're thirsty. Those are feelings that they have. That's a subject. That's something they know I can't see. Now, as far as object, I can see a person walking as if he may be drunk. I can see a person limping. I can see a person squirting blood. I can see a bone sticking out. The objective thing is, so and this is across the industry, AVPU, alert, vocal, pain unresponsive, and SOAP, SOAP. Carl has it SOAPE because he does with wilderness. S is subjective. What happened? When did you get sick? What's the nature of illness? How far did you fall? What happened? What's your pain on a scale of 1 to 10? When did you start having diarrhea? When did you start being sick? When did you start bleeding like that? Etc. Now, once I go from subjective, then I go into O for objective. Just like in a hospital, what are the signs and symptoms of what's going on? Now, a sign is something I see. I can see he's limping and dragging blood. A symptom is he's telling me subjectively that I feel dizzy. After I get S is in, it's another memory called sample. After I get the symptoms, I immediately go for allergy. Dave, why do you think I go for allergy? Why do you think they always go for allergy? Number two thing whenever you walk into a hospital or anytime you talk to a medic.
Probably you just don't want to try to treat something as though it's a severe medical thing uh, when it's actually a reaction to something that they're already knowledgeable about.
It could be, but it could be that they've got an ID bracelet that they are allergic to bee stings.
Mhm.
At which time they might have an EpiPen and we can help them. We can't do it, but we can help them give themselves a shot with an EpiPen, which we'll show you guys later how to do. Allergies can be pretty nasty. They, I've got a doctor friend of mine, did a lot of training with him. He can't work in an emergency room anymore because he's got an allergy to latex, and everything around an emergency room is latex gloves, etc. So the first thing after signs and symptoms, we go straight for allergies. Then we ask the person, what meds are you on? And I don't need to hear metformin and not so bit of a. I'm on heart medicine. I'm on diabetes medicine. I'm on blood thinners. I'm on. That could tell me some of the things that is already wrong. I was at a car wreck 3 or 4 years ago. Woman hit a tree, and I asked, "What meds is she on?" She says, "I've got heart meds and I've got blood thinners and stroke meds because I've had like 3 or 4 strokes and I've had a couple of heart attacks and a couple of brain operations." And boy, guys, all I'm thinking of is paramedics better get their tail here because I don't want to bear and prepare. I don't want to have to start CPR in this gal. Anyway, what meds do they have? Then I'm going to ask, what was the last thing that you ate? What was the last thing that you drank? What is the last thing that you smoked? What is the last period you had? In case a person in a wilderness situation has a, um, a pregnancy issue type thing that can be very, very life threatening. So, sample, signs, symptoms, allergy, medications, past. What's previous? When was the last time you pooped? When was the last time you ate? When was the last time this? Now, I'm not going to do that if somebody's bleeding on me. I'm going to do that more if somebody's bending over screaming that they can't walk. You see? Now, if they walk like eggshells and they're holding their gut down to the right, I might think might have an appendicitis. In a wilderness thing, we can't do a dang thing about that. We call in the helicopter. We can't do anything about it. If it happens when the grid's down, we better have a surgeon around. Okay? So, signs, symptoms, allergies. What is the medications they're on? What's the previous in and out? What was the last intake? What was their previous medical history? What was the last thing they ate? What was the last time they peed, poo, menstrual, etc.? What are the events leading up to it? I was doing real good, but it was 103 degrees out there and I started getting dizzy. My mouth got real dry. I started sweating. Well, there you go. So sample, signs, symptoms, allergies, medication, previous illnesses, last in, last out, and events. We go from there to what is assessing the problem. Okay, let's come up with a game plan, guys. What's the list that it could be? Let's take a look at it. What do you think? Then we get into P, which is planning, and then we get into environmental challenge, or what happens? Do we have to get a helicopter in here? Or do we just put them up and keep them in the infirmary in the medic place for the next 4 hours or whatever? Now I've covered a lot of stuff here. Really, it's just like a machine gun. I understand. Saying safety, number one. Introduce yourself. Ask for permission to help. While you're talking to them, you're assessing AVPU. Is he alert? Is he vocal? Okay, does he respond to pain? Is he unresponsive? We're not doctors. I can't say he was unconscious, but I can say he sure didn't respond to me yelling, "Hey, what?" While doing that, if he didn't respond, he was unresponsive. So I'm going to be making notes at this. What is AVPU? I'm going to be making notes at this. Sample, just like the doctors do. And it's just like they do at the EMTs and everyone else. Signs, symptoms, allergies, medication, previous illness, last in, last out, and events leading up to it. This is all covered under this one overall SOAP, which is subjective, objective, assessment, plan, and then the environmental. Okay? Now, as part of objective, I'm going to want to find out some stuff about this guy's body. Okay. I'm going to want to find out what their heart rate is. Anybody know what a normal pulse rate is? About 60 to 100.
60 to 100, yeah.
Yeah, about 60 to 100. Now, Caden, my grandson, he did a sports, or he did an ROTC thing in high school. He just went to 120 and stayed there for a half hour. Turned out he had a serious heart problem.
Huh.
And that was the first sign of it, that he had a serious heart problem. To him, he grew up with this. He didn't know any different. That's the way everybody's heart should be working, right? So we find out what's going on. We find out what his pulse rate is. We take a pulse rate, very simple. I can feel a person's, well, I can sit there and feel their pulse, 3 fingers right in here, and count it for 30 seconds by the clock. And by 30 seconds by the clock, then all I do is I just double that number, and I've got, is the person very low pulse rate, or the person very high pulse rate, or the person normal pulse rate? Now, babies might have a pulse rate normally of 120. Smaller kids have higher ones. Older people might have a lower one. Somebody might be on medication that causes it to be different. But just as an average thing, 60 to 80, 60 to 100. I want to know what the respiratory rate is. I want to know how many respirations. So respiration is a breathe in and a breathe out. Now, if you tell somebody I'm going to count your breaths, they're going to look at you and count. They're going to have different breaths. Trust me. So you sit there, you had your finger on their pulse for 30 seconds. You keep it there for the next 30 seconds. You put your hand on their chest, and you're counting not their pulse the next 30 seconds. You're checking their breath, which should be between 12 and 20, 12 and 18 to 12 and 20. Okay? So that will give you what is their pulse rate. That will give you your breaths per minute. Okay? You write down, of course, what time you did. Capillary refill. By pushing down on their fingertip, it takes about 2 seconds for the white bleach to go away and for the blood to come back and start looking normal. We always do that when we put a splint on somebody. We always do that when we put a bandage on somebody, or compression bandage, or H bandage, etc. We're checking circulation, sensation, and movement to make sure we didn't cause a tourniquet if we didn't want to, and cut off the blood. So we're going to find out what the capillary refill is. And we write down the seconds to go from white to pink after the fingernails push. Blood pressure. Now, we're normally out there with a blood pressure cup and a stethoscope on us, right? If I feel their feet and their feet are warm, they've got a blood pressure of 90 at least, systolic 90. Okay? It's not real bad. Normally it's 120 over 80 or something like that. Some people have 100 over 60 or whatever. But anyway, it's not bad. If they have warm feet, I know they've got blood pressure of at least 90. Okay? Now, I can also go in on parts of their ankle, hard to show on this, and I can see if they have blood pressure on one of their vessels and be able to count that. So if I can get a blood pressure on their feet, it's going to be 90. If I can't, I'm going to go to right here and try to get a pulse and blood pressure. And if I can get that, then I've got a blood pressure systolic of 80. If I can go in on the femoral artery right in the groin, I've got a blood pressure of 70. If I can only get it. Now, it used to be in 2010, we taught CPR was you always went for the carotid artery. You immediately try to do that and count. Found out in 2015, they changed the standards that we don't do the pulse anymore. 2015, they got look, listen, feel, where you put your ear down and feel respiration. Now what we're teaching is look at the guy, is he breathing or not? If he's not breathing, start CPR. Why? Because doctors and nurses were spending 30 seconds to a minute sitting here trying to count and find his pulse when they should have been pumping the pump to keep the fluid going to keep the captain alive. I get real technical on this stuff, right? Now, Temperature. I don't have a thermometer with me. Is he hot? Is he cold? Like every other mother in town, right? You're burning up, dude. Not burning up, right? LOC, level of consciousness. Is he alert, vocal, pain, unresponsive? Skin color change. Okay. If he's got a real heat issue, he might be red. If he's got a real cold issue, he might be blue. If he's a person or she's a person of color, look inside the lips and the eyelids. You can see a different change of skin color. Okay. You go into the sensation, movement. You go into skin activity. If somebody's dehydrated, you pull your skin up like this, it stays in a little mountain valley there for a while. Okay? If that's the case, get some hydration in them, propel, etc. You see, guys? Is his pupil really dilated? Is his pupil really pinpointing these mean things? Write this stuff down, give it to the medic, etc. Write it down, and then in 30 minutes, check it all again. Is he calming down? Is it getting better? Is it getting worse? Does this make sense? So let's look here. Level of consciousness, ABPU. And I think I've got that too. I've got that on the same thing I've sent. And that is he alert? Is he vocal? Respond to pain, or is he unresponsive? Pulse rate, counted wrist or neck, beats per minute. Respiratory, number of times chest comes in and out. I say, kind of do a little trick. Pretend you're doing his pulse and count his respiration. Cap refill. There you go. Thanks, David, because it's easier if they see it and have this, you know?
Absolutely, yeah.
Skin temperature, back and hand. Okay. Is he hot, cold, normal? Skin selectivity? There you go. Blood pressure. Well, we just went over this, didn't we, guys? Good. Okay. I've covered a lot. Now, why do we want to find all this stuff out before we move the guy or put a band-aid on him? Well,
Well,
ask.
you don't want to injure him further if he's got something going on that you may not have observed immediately.
Yeah, and if he's bleeding, you don't get to it and stop because you didn't notice he's on his back or something and he can bleed out. You have to know what you're doing before you start treating.
Right. Exactly. No, you're absolutely right, Marcy. Absolutely right. What I'm doing is I'm saying, if the guy's like, ah, dang, I'm hurt. Yeah, you can treat me. Give me a first aid kit. I'm not as worried about that guy as I am whose eyes are in the back of his head. Might be laying on a rake like Marcy was talking about. You see? He might have been snake bit or something like that. He might have been snake bit and had an allergic reaction. He might have been bee bit and had an allergic reaction. Might have touched latex. Might have talked peanuts on the old Southwest Airlines, you know? And they stopped serving peanuts on Southwest Airlines, but it used to be you couldn't have any peanuts for three rows before somebody had a peanut allergy. It's bodies, but we need to find out what it is before we start jumping in there, because the most screaming person might be the least one hurt. You get something like a cut across the front of your head, you're going to bleed like a stuck pig. You know, oh my God, oh my God. You're paying attention to him instead of the guy who's choking to death. You see? What we went over today was scene safety, acceptable risk, getting permission, introducing yourself, asking questions. Now, while you're subconsciously or you're not telling him ABPU, is he alert? Does he respond to vocal? Does he respond to pain? Is he unresponsive? While doing this, we're still doing the SOAPy, which is we're doing the subjective. How bad does it hurt? You see? It sounds complicated, but after a while, just like doing evening drills or anything like that, after a while you get to where you kind of think with this data. You see? But it sure is nice. They have a waterproof little thing here that says this is what you check and this is what you down. Peace. Thanks, guys.
Sounds great.
Hey, let's hear for Jim.
Great.